Good afternoon, and welcome to this month's Northern Virginia Health Policy Forum. I'm Jim Scott, President of Applied Policy, a consulting firm based here in Alexandria, Virginia. My colleagues and I host these gatherings to promote an exchange of ideas and approaches to the issues shaping 21st century American healthcare. Emerging data from this past year indicate that the opioid epidemic, which has gained force annually over the last decade, is showing no signs of abating. As the search for an effective prevention and treatment intensifies, non-opioid alternatives to pain control offer hope for both patients and healthcare professionals. Our guests today are here to discuss these new approaches to pain control and the necessary steps to ensure their availability to patients who might otherwise be put at risk for opioid abuse. Let me first introduce Dr. Sanjay Sinha, founder and Chief Innovation Officer of Gate Science and lead anesthesiologist at the Connecticut Joint Replacement Institute. Also with us, Drew Riddle, President of the American Association of Nurse Anesthesiology and an Associate Professor at the Texas Christian University School of Nurse Anesthesia. Both are actively practicing, so thank you for taking the time to be with us today. Now let me turn it over to the panelists to introduce themselves. Dr. Sinha, let's start with you.
Good morning. Thank you for inviting me to this panel. It's a pleasure to be here. I'm a practicing anesthesiologist in the Hartford area in Connecticut, and I specialize in orthopedic anesthesia, the whole spectrum of very simple cases as carpal tunnel to the complex total joint replacements and complex spine surgeries. I'm also the medical director of two ambulatory surgery centers and the lead anesthesiologist for the Connecticut Joint Replacement Institute. I'm also the fellowship director for the regional anesthesia and acute pain fellowship program in our hospital.
Thank you, Dr. Sinha. Drew, I'll turn the question to you next.
Yeah, thanks, Jim. Great to be here. I echo Sanjay's appreciation of the invitation. I'm Drew Riddle. I'm a practicing nurse anesthetist in Fort Worth, Texas, as well as a researcher in the area of pain management and pharmacogenetics as it relates to pain, and also faculty here at TCU in our School of Nurse Anesthesia. And I have the pleasure this year of serving as the president of our national association, which represents approximately 71,000 members, both practicing nurse anesthetists and those that are in training programs. So I appreciate being here.
Great, thank you. Drew, looking at the big picture, where do we stand as a society when it comes to pain control? Are we more on the tough it out approach, or are we leaning towards the idea that no one should have to experience pain following a surgery?
Yeah, it's a great, excuse me, that's a great question. And, pain is certainly it's a very deeply personal experience. And we've all probably know someone or have seen someone who has something that has injured them or hurt them, and I'm perfectly fine, I don't need anything, versus the person who has what may seem to be a rather simple, easy injury that, oh my gosh, they're absolutely writhing in pain. And we've had this swing in the past. I've been in practice almost 25 years, and we've certainly seen a swing in the healthcare system around pain and pain control. This notion that we're going to have to tough it out is not appropriate. Our patients deserve appropriate pain control. If left untreated, acute pain can become chronic pain, and that has lasting implications beyond just the pain episode. But this notion that there is absolutely zero pain at all ever after a surgical procedure is also probably a bit far-fetched. And so there's a happy medium in there where patients are comfortable and accepting of where they are in their pain level, but yet are able to still function and work and get around and rehabilitate after, in our case, as Sanjay and I were in the operating rooms after surgical procedures in particular.
Thank you. Dr. Sinha, I'm curious about your experiences. What frustrations do you face with the typical prescribing patterns for pain control?
Yeah, so before I answer that question, let me give you a startling statistics. It was based on a study that was done by the Centers for Disease Control in 2017. And they looked at a large cohort of patients who were given opioid prescriptions. And what they found was that if you give one-day prescription of opioids to a patient, the risk of that patient continuing to use opioids 1 year, 6 out of 100 patients would continue to use those opioids. If the prescription was given for 10 days, 13 out of 100 patients would be using opioids, would be at risk of using opioids at 1 year after that prescription. And if a prescription was given for a month, a third of those patients, 30 out of 100 patients would be at risk of using opioids 1 year after that prescription. So there is awareness right now in our community, in patients population, as well as in the surgeons and the anesthesiologists, that the opioids given to opioid naive patients in the surgical suites and postoperatively increase the risk of the patients developing chronic opioid use or addiction. But despite that awareness, opioid prescriptions are still being made because there are no good alternatives to control the entire episode of post-surgical pain that ensues after a surgical procedure.
Thank you. Drew, do you have anything to add here? For example, would you say the opioid epidemic is rooted in problems with people, the system, or the availability of pain control options?
Yeah, it's a good question. Sanjay really laid it out well for us that traditionally in the anesthesia space, back up 20, 25 years, pain control, the foundation of pain control was opioids, acute, highly powerful intravenous opioids that we would give to patients before, during, and then continue after their surgical procedure, transitioning them then over to oral pills that they may go home and take for days, weeks, or potentially even months. And the system at the time and the technology at the time really wasn't there weren't alternatives, really decent alternatives in place. And so we had to do something. Now, we recognize that opioids and all of the side effects of opioids, you can't turn on the news without hearing something about someone who has been struck by the opioid epidemic or has had some sort of really terrible outcome from taking opioids. Now, I think the good news is now we're seeing availability of other options, both in the acute care space and in anesthesia in particular, with the advent of various regional anesthesia blocks, which means it's, to explain it to a patient, we tell them, well, we inject medication to help numb up part of the body where we're working, and hopefully that lasts a little while to help you with that immediate acute pain postoperatively. But also non-opioid alternatives, enhanced recovery after surgery, or ERAS, is a big piece of what we're all incorporating into our practice, which is really a interdisciplinary, multifaceted approach to pain management that begins to remove opioids as the foundation for pain control.
Dr. Sinha, can you give us a glimpse into the patient's perspective of an episode of pain? For example, how did the first 48 hours of dealing with pain compare to the 1 to 4 week period following that?
Right. So it's important to understand a pain profile of a patient having a surgical procedure. The period initially begins in the first 48 hours, where you have really intense pain after surgery. And after that, the patient transitions to what we would call like a transitional phase, where the pain starts to resolve. The body heals itself, the pain starts to resolve, and gradually the pain scores or the pain experience goes down till there's complete healing and the patient has no pain at all. This transitional phase can last from days to weeks, depending on the kind of surgery that the patient has. Now, in the first 48 hours, we have come up with great methodologies to control that acute intense pain that happens in the first 24 to 48 hours with our nerve blocks, multimodal medications. And then in that transitional phase, these nerve blocks, they usually last for about 24 to 48 hours, sometimes for maybe up to 3 days. But when the patient is in that transitional phase and they are usually at home, then the medications, including opioids, become the bedrock of management of that pain. And if that pain is not well managed, the patients can then have inappropriate sort of have an unpleasant experience. They can start using a lot of opioids, and their side effects start to become more evident, usually nausea, vomiting, constipation. And if the pain is really not well controlled or the healing doesn't occur, then these patients go on to become chronic opioid users, and then your whole surgical outcome is very poor. And so it is very critical that we control the pain in that early phase as well as in that transitional phase while the patients are usually home and recovering. And so that entire episode of post-surgical pain has to be managed. And right now, our focus has been in that first 24 to 48 hours.
Drew, do you have anything to add here based on your experience?
Yeah, I would just add that I think Sanjay absolutely described the way the sort of typical progression happens. I think one piece that we sometimes either overlook or don't recognize as much is the psychosocial impacts that long-term chronic pain has on patients. And so someone has a surgical procedure, they have reasonable pain control in that intense acute period that was just described. Maybe that transition period wasn't quite as well controlled as we would have liked. That means that perhaps their rehabilitation, their ability to do, say, physical therapy after a knee replacement, for example, which is we know is so critical to get up and get moving and begin to restore some normalcy in your life. You can't do that. You take opioids to help with that pain. You get some of those side effects. I need some more opioids. I'm not able to get up and move around. And then the pain becomes quite consuming. In fact, in many patients, it is all consuming. And there is significant psychosocial impacts. You know, we've seen, I've seen examples, unfortunately, of patients who've ruined family relationships over poorly controlled or uncontrolled pain. And so it does go beyond, we just need to get the pain controlled, but there's really a continuum there of pretty tragic outcomes that can happen in patients that don't get good chronic long-term pain control.
Building on that, Drew, could you share some of the modalities and strategies you typically use with your patients to control pain?
Sure. So this is speaking sort of through the lens of typically acute post-surgical pain, working in anesthesia and taking care of patients that are getting ready to have a myriad of surgeries. And you know, we still use and I still use in my practice opioids, but it's in a much more limited fashion. And so if you think of sort of a pyramid, the way I describe this to patients is if you think of a pyramid with the foundation or the base of that pyramid or the foundation and the base of the house, we're going to use that foundational pain control. We're going to use medications that aren't opioids for that. So it may be other non-opioid IV medications. It may involve, as we've alluded to a couple times, peripheral or nerve blocks of some kind where we numb up the area of the body using hopefully as long-acting as possible medications that help keep that area of the body numb. And then a lot of this is talking to patients preoperatively and setting ground rules and our ground kind of the groundwork of what are the expectations. I expect you to be reasonably comfortable, but you're probably not going to be absolutely, totally 100% pain-free in this next, day or two. But we're going to get you to where you can get up and you can move around and you can do things that we need you to do to help recover from your surgery. There are a large number of newer medications that are good at controlling pain. We call that multimodal analgesia. So we use a little bit of several different medications that all treat the pain pathway in different places before we even start the pain process, maybe even before we start surgery. And then we think about, that kind of intermediate transition period of what can we do with the patient beyond giving them opioids to try to keep their pain control. And that can be appropriate rehabilitation techniques, that can be cognitive behavioral therapy. There's a myriad of options that don't all involve just giving the patient more medication.
Dr. Sinha, what are your thoughts on this?
Yes, so as Drew alluded to, multimodal medication forms the bedrock or the strategy that we use in managing pain, and within that strategy, as again Drew alluded to, we use medications from different pharmacologic classes to try to maximize their benefit and try to reduce their side effects. And by using all these medications from different classes, we are able to provide, reasonably good pain control to these patients. Within this strategy of multimodal strategy is also nerve blocks forms a part of that strategy. And the nerve blocks, they are really, really powerful way of controlling pain because it essentially blocks the transmission of pain impulses from the periphery to the brain. So once the nerve block is performed, anything distal to the nerve block or anything at the surgical site is completely feels numb. That numbness does have certain problems. So some patients perceive that as unpleasant, having a numb hand, and also there's the risk of falls, of not being able to do physical therapy because the nerve blocks, they not only cut off the sensation, but they also make the extremity or the area numb or weak in terms of motor weakness. So the patient may not be able to walk. They might be at a higher risk for falling. So there are these issues with nerve block, as well as, even though they are a powerful way of controlling pain. And so we have let me tell you what strategy that we have been using to try to control that entire pain cycle, so to speak. About 3 years ago, I co-founded a company called Gate Science, and we created a product called Relay. Now, this Relay device is a device that you can place right next to a nerve, a target nerve, depending on the location of the surgery. And this Relay device allows you to inject a Novocaine through that device to create that nerve block, which really works in that first 24 to 48 hours after surgery and blocks that intense pain. Once that nerve block wears off, the Relay device has an integrated pulse generator that can transmit tiny pulses of electricity to the target nerve and neuromodulate that nerve and continue to block the transmission of those pain sensations at the peripheral, at the location of the nerve, as well as in the spinal cord, thereby prolonging the duration of the pain control. And this Relay device can be left in place for up to 28 days. So it has the ability to be able to control the entire episode of post-surgical pain, not only the early intense pain in the first 24 to 48 hours, but also the transitional pain that occurs for days or weeks after surgery. And so it's a novel device that we have created, and we are in the IDE phase where we have received approval from the FDA to do human trials, and we are in early clinical trials right now.
Thanks. We'll come to more about the Gate Science device in just a minute, but Drew, how do you see the technology evolving to address postoperative pain, and where do you see the major opportunities?
Yeah, Sanjay certainly described an incredibly novel approach, and certainly from a science perspective, it really makes a lot of sense that we would have the opportunity to both numb up acutely and then have some degree that piece in the middle really is the part that's very, very difficult. That I got you through the first day or so after your surgery, but the next week or two, it's going to be kind of rough because up until now, there's really not been a ton of good options there. Beyond pieces of technology, I think we in the healthcare space, the entire interdisciplinary team is trying to be hyper-focused on ensuring that patients are as comfortable as possible and that the foundation or the bedrock, as was said earlier, of that are not opioids. Although opioids may have a place in certain instances, that physical therapy, rehabilitation medicine, and the like are really beginning to understand, along with us in the anesthesia space and acute pain management space, how to better techniques, therapies, et cetera, that begin to help the patient heal, but help their pain as well. We also know that interdisciplinary team, when it's surgeon technique all the way through long-term rehabilitation, all of that is changing to really put the patient front and center on understanding the expectations of what should I be feeling, what is normal to be feeling at this point in my recovery process, so that there's really clear expectations that this is a normal feeling at this point. And at week 1 or week 2 after your surgery, for example, I would expect you to have this sensation that you're having right now. And that's a good thing. That means that your body is healing and beginning to, take care of the injury that was the surgical piece. So, we have a lot of holistic approaches as well that are beyond medications and devices. But we, alluded to it earlier a bit. There's behavioral therapy and the like that really, really help patients and are incredibly powerful. And the data, the science around those is really compelling, that we probably need to think about integrating a little bit more of a holistic approach to pain management than perhaps we've done in even the recent past.
Thank you. And Dr. Sinha, can you tell us a little bit more about the functionality of the relay device, such as the conditions it's used with and how it works?
Sure. So as I alluded to, the relay device is actually, if you think of it from a conceptual point of view, it is a device that uses nerve blocks as well as neuromodulation, two technologies or two techniques that have proven to control pain. They both have their limitations, but combining the two into a single platform is really sort of the opportunity to be able to fill that analgesic gap that exists in that transitional period. The device is controlled by an app on your phone. And so when the patients, when they go home, they have an app that they can use the device or titrate the amount of electrical pulses or the strength of the electrical stimuli to be able to control their pain or match the intensity of the electrical current to the level of pain that they're having. So the patient feels in control while they are at home, recovering at home. So that's one thing. The second thing is because we have an app now, which we call the Gatekeeper app, it creates a digital platform to be able to communicate with these patients while they are recovering at home. Traditionally, or now, even currently, once the patient leaves the hospital or the ambulatory surgery centers, we as anesthesiologists who manage acute pain, are the experts in acute pain, we sort of lose track of those patients. And maybe this digital platform will be a way of communicating with the patients, gathering their pain scores, gathering patient-reported outcomes or patient source outcomes in terms of how they are feeling, how they are reacting to the medications. So the digital platform is another important component of this relay system. Ultimately, what we would like to do is to be able to gather enough information for different surgical procedures and to be able to create a profile, so to speak, for each surgical procedure, and the patients can then match their recovery based on those cohorts. How far are they deviating from the average or the norm of how a traditional normal patient would react? And so you can find outliers. You can then aggressively try to address their needs, and also the psychosocial components in terms of anxiety, depression, sleeplessness, mobility. All those things can be tracked through this app. So it's a comprehensive way of looking at acute pain.
Giving the patient control over the app, is there any risk that they, turn up the electricity too high or don't have it on enough, or how does that work?
Right. So, when the relay device is placed right next to a target nerve, there's a programming that happens right after placement. And what that programming does is it determines the limits between which the system is going to operate. So we find the lower safe limit and the upper safe limit, and then the device is going to operate within those limits that we have set. So when the patient is home, they are essentially operating within the limits that we have set. They cannot overstimulate themselves or understimulate themselves. So that is sort of an advantage of the programming that happens preoperatively or prior to surgery.
Drew, you mentioned behavioral approaches to treat pain and that they need to be used more. Could you give some examples and share some of that with us?
Sure. Yeah. The lack of control that you get as a patient in the healthcare system is pretty profound. And you really do have this sense of vulnerability, or, gosh, I just hope everything goes well, but I really have no control as a patient, as an individual over, um, for example, my pain control, my pain management. And the idea of empowering the patient from a control perspective, there've been multiple studies that show that if a patient, an individual, feels like they have some sense or some degree of control, that their perceptions of pain and their pain scores are less. And when we remove that sense of patient control and the patient feels like they're sort of spiraling out of control, their pain scores and perceived pain scores are much higher. We equate that then to doses of pain medication, opioids or non-opioids. And we see in the data that it suggests that when patients feel like they're in less control, they have higher needs for pain medication, pain prescriptions. So speaking a little bit then to sort of the behavioral aspect of that, and I'm not a behavioral therapist, so I'm a little bit out of my lane here, but in my clinical experience and seeing patients undergo sort of these episodes of pain in which they feel they have very little control. Therapy, behavioral therapy, psychosocial interventions that begin to help the patient understand the sense of control that they do have really significantly starts to change perceptions of pain and ambulation, moving around, getting up, beginning to be recover from that, in this case, surgical experience, for example. It's interesting. We saw in 2012, there was a dispensing rate when we look at opioids that were written prescriptions. 2012, there was 81.3 prescriptions of opioids for every 100 people. 81.3 per 100. Since that time, we've seen that dispensing rate, prescription rate go down, but it's still 43 prescriptions per 100 people in 2020. And what we know has happened during that time is education in the public space, as well as amongst us as healthcare providers. But we also have seen the opportunity for patients to understand the ramifications of the decisions they make for treatment and therapy. And so including the patient in that shared decision-making model on the front end, prehabilitating the patient, really giving them this opportunity to feel that they have a sense of control over their surgery, their recovery immediately in this intermittent phase, and even in long term, we know moves the needle on outcomes.
Thanks. Dr. Sinha, is there a need to sort of re-educate or educate your colleagues and their patients about any new approaches to pain control?
So the answer is definitely yes. But I must add that there is a lot of awareness within the community, the anesthesiologists, my colleagues, physicians, as well as in the general public as well. We have a lot of conversations when patients come in, especially teenager patients with their parents about postoperative pain management, the use of opioids, how we can minimize their use, how we can avoid their use. And so there's there's a lot of awareness about it. But education obviously is important to be able to disseminate and spread the word, and so it becomes widely used. One of the ways, one of the strategies as part of the multimodal was that ERAS, enhanced recovery after surgery. It is an idea that you enhance the recovery after procedures by taking care of pain, by moving the patients faster, by having them, have more control in their recovery. So there are different aspects of different elements that we keep learning that add positive value or incremental value in the recovery and experiences of patients. And as those data or as those experiences are understood and documented, we can then educate and spread that word. So there's always a need for education, as well as the newer technologies that are being developed. Once they come online, significant education will be required of the physicians and the anesthesiologists to be able to implement and to be able to deploy those technologies on patients.
Thank you. Drew, anything to add about needed educational efforts?
Yeah, I couldn't agree more that we can always, as clinicians, we can always learn more, learn better, be more skilled in our approach and care for patients. I will say, as a nurse anesthetist and as an educator, a nurse anesthetist educator, I'm very proud of the fact that in our educational programs, our doctoral programs, that we have comprehensive physiology, pathophysiology, pharmacology that is being taught at the entry into practice level, specifically targeting both acute and chronic pain. And so our individuals that are in training programs right now and are being educated in the provision of anesthesia care are learning with an interdisciplinary team to understand how they interact with patients and can offer opportunities for pain control, and where other members of that team are also critically important for ensuring that the patient has, again, that sense of control over their care, but also what do other disciplines bring into this kind of melting pot, if you will, of individuals in this interdisciplinary way. I feel like we have a really good toolbox, if you will, as nurse anesthetists are graduating and are entering into the workforce, of opportunities for pain management beyond, again, that bedrock is not give a patient a whole bunch of opioids and they may not complain of pain in that first couple hours, but boy, the outcomes can sure be terrible. For the practicing clinician and those of us that have been out in practice, it really is incumbent upon us as individuals and our professional societies and healthcare as a whole to ensure that we all remain both up to speed on current data and techniques, but then also potentially some retraining around in the case of Sanjay's device when it comes to market. I look forward to learning how to implement that in my practice, and we have partners in industry and pharma, in devices and drugs, et cetera, that help us to understand what is available and how we might incorporate that appropriately into our practice. And as clinicians, we just need to be open to that and be willing to learn and understand ways that new, exciting ways that really can move the needle for our patients.
Thanks. So you alluded to it, but what incentives do you think are driving clinicians to embrace and support the introduction of non-opioid alternatives?
I think the incentive piece, this is maybe the conversation or a discussion, is this a carrot or is this the stick, right? This idea of, do we incentivize or is it punitive if you don't? And actually, I think there's a little bit of both going on right now. One of the big drivers in my personal practice and in the practices in which I have an opportunity to interact is, quite frankly, peer pressure from other clinicians that are really developing comprehensive, incredibly robust pain management programs within their health system or their facility, their surgery center or their hospital, and learning from individual provider and patient experiences that really are specific to that, location or surgical technique or particular service line in the anesthesia space. The other piece that I think is incentivizing that, and Sanjay alluded to it just a moment ago, is our patients are demanding this. The educated, informed patient is asking me in my practice preoperatively, am I going to get fentanyl, for example? And they're calling it out by name. It's a very powerful opioid. It is something that we've used in the anesthesia space for quite some time, but with all of the illicit use of fentanyl and unfortunately just terrible epidemic of contaminated fentanyl, I'm having patients ask me, please don't give me that medication. I know a friend, I have a colleague, somebody at my school, in the case of the teenage patient, for example, they died because of an overdose of that, and I don't want that to happen to me. And that's great to hear that we have an informed group of patients out there that are coming to us and saying, help me understand what are my options, and can those options not include a bunch of opioids? So the patients are driving that. We're driving that as clinicians, and then payers are there's a piece that I think we'll get to that in a little bit, but there's some requirements even in some of the quality reporting metrics that we ensure our patients are receiving multimodal pain management beyond just a big old dose of opioid and then hope for the best.
Thanks. Dr. Sinha, same question. What incentives do you see as driving anesthesiologists to embrace and support the introduction of non-opioid alternatives?
Yeah, so I think it has to do, as Drew alluded to, the informed patient that comes in and demands non-opioid reduce the use of opioid in patients intraoperatively as well as after surgery. So that's sort of an important driver. There's also, within the clinician community, we sort of live in the community, and we see the societal sort of crisis that's happening with the use of opioid and the opioid crisis and the opioid epidemic. And so we want to inherently do good to our patients and to try to develop strategies, techniques, medications that empower us to reduce the use of opioids and deliver the same level or even better level of care. And so there's this inquisitiveness, there's this inventiveness that drives us and is an incentive for us to do better. So patient and then education of clinicians, the clinicians, they feel this urge to go and learn new techniques at conferences or CME, continuing medical education seminars, where they learn new techniques because their patients need it, the patients demand it. The surgical community is now becoming very aware and in requiring nerve blocks and requiring reduced opioid or opioid-free anesthetic techniques. And so it's a multifactorial issue, but the bottom line is that everybody is aware that opioids are, opioid addiction or chronic opioid use leads to very poor outcomes, and we should do everything that is required to be able to reduce its use.
So, Dr. Sinha, from a patient perspective, if I go in for a surgery and I say, I don't want to leave this hospital or ambulatory surgical center with a prescription for opioids, am I trading off? I'm going to hurt a little bit more than I would if I had opioids? Or are these non-opioid alternatives that you're talking about sort of equal to the pain relief I would have if I used an opioid?
Right. So that's a great question. It really depends on the degree of invasiveness or the type of surgery that the patients are having. There are a number of surgeries where can be done safely with with non-opioid medications, as well as the pain control after surgery can be controlled with non-opioid medications. But there are certain surgeries where the pain burden is extremely high. So for example, a rotator cuff surgery in an ambulatory surgery center or a total knee replacement, these surgical procedures have very, very high pain burden. And we can use, nerve blocks, we can use our multimodal medications, but despite that, you have to use some opioids. Now, we can try to educate our patients. We can come up with technologies or devices like the relay system where you maximize all the other options of controlling pain before you take the opioid. So you would take all the non-opioid medications, all the non-opioid therapies that may help you alleviate that pain. And if you still have breakthrough pain, then you go to the opioid. So patient education, that in some cases opioid may be necessary, but then it shouldn't be taken freely, but it should be taken much more sparingly after all the other modalities have been completely used.
Thanks. Drew, we have a question from the audience that I think is for you. Has there been pushback on CRNAs regarding getting non-opioids on hospital formularies?
Yeah, it's a good question, and it's something that I don't know if it's specific for nurse anesthetists. That there's not in most facilities that that utilize nurse anesthetists. There is one formulary that is available to anyone administering or prescribing medication that may be within that particular facility. But there absolutely has been pushback at facility system levels about especially some of the newer, perhaps pricier medications that are available that have really good data to suggest that they help to alleviate pain acutely in the immediate and even intermediate phase of postoperative care, and unfortunately are not available on formulary in that hospital, in that facility. And despite sort of the clinician push for, hey, we really think this would make sense, the data suggest in our patient population this makes a lot of sense, and it is another arrow in the quiver, if you will, to reduce the pain burden, as was so eloquently described, without the use of an opioid. And unfortunately, if the medication is physically not available to be given, or device, if there's a device involved, is physically not available to be utilized, then the patient ultimately suffers there.
Thanks. And since you mentioned price, let's turn to the regulatory side. I'd like to know where the disconnect exists between policy and widespread adoption of the clearly groundbreaking non-opioid alternatives. Drew, when it comes to introducing new methods of pain control, what hurdles do you face with your colleagues and patients in actually using those?
Yeah, unfortunately, it is a bit of a disconnect, as you said, Jim. That there's sort of the we need to provide the best possible care for our patients, but we also need to ensure that there's appropriate reimbursement for the techniques, the devices, the procedure, the medication, et cetera. And we are recognized, CRNAs are recognized and reimbursed for anesthesia procedures for surgery, but payers do not specifically recognize any clinician payment for an opioid-free or an opioid-sparing or an opioid reduction type of an anesthesia technique. There aren't any CPT codes, for example, that recognize opioid-free or opioid-sparing anesthesia services. At times, quite frankly, there is an increased provider burden. So as an anesthesiologist or a CRNA that employs some of these additional techniques or additional therapies, sometimes that's actually a little bit of a higher burden on the provider and on the time that it takes to do those. While appropriate to do, there are times in which those techniques may not be uniquely reimbursed. And so since it's, you know, not always recognized for payment, it may dissuade somebody from offering that for the patient. And then ultimately the downstream effect of that from a policy perspective is it can decrease access to some of these services for our patient population.
Thank you. And Dr. Sinha, what's your perspective on this?
Yeah, so, you know, the newer medications, newer technologies, it is always a challenge to bring them into the hospital formulary or the ASU formulary. And to be able to overcome that challenge, it is essential to do sort of a lot of studies, prove outcomes, demonstrate good outcomes, and so sometimes access to the latest and the best opioid sparing methodologies may not be available, and I think you know, forums like these where administrations or administrators who sort of run you know, are experts in reimbursement and outcomes, they should sort of focus in on these latest technologies and medications, and incentivize them to be used in patients, because downstream they do make a difference in the opioid crisis, in the chronic opioid use, and patients' experience of postoperative outcomes. And I think education of these in these forums is essential to sort of understand the latest techniques and technologies and medications that are available, and how to get them approved and remove the barriers to be able to use them more frequently in appropriate patients.
So we hear about in the news about the fentanyl epidemic. The opioid abuse epidemic is still a public health emergency. And it seems like it's only common sense that opioids have been around for a long time. Many are generic and less expensive than the newer innovative approaches. So isn't it, if policymakers want to stop the use of opioids, don't they have to make an investment in paying more for non-opioid alternatives, where the value they would derive is from less exposure to opioids as part of a surgical encounter, and then that would go towards fighting the opioid epidemic and the fentanyl problems, at least to the extent that it comes from encounter with the healthcare system. So that seems common sense. Why do you think that doesn't seem to be what the federal policymakers are doing? Drew, you want to go first?
Sure, I'll take a stab at that. I think you know, there actually, you're exactly right, Jim. The way you lay that out, it makes a lot of sense. But there's actually some additional, I think, data that we clearly know exist, that reducing opioids reduces hospital length of stay. Reducing opioids reduces the amount of post-operative complications our patients see, both directly from the administration of opioids, but the other sort of adjacent sequelae of that, of I'm too tired and too sleepy to get up and move around, so I actually developed a blood clot in my leg and now I'm back in the hospital, for example. So you know, why is that happening? I wish I had the golden or the crystal ball to see, you know, why does that happen? I think part of it is incumbent on us as clinicians to explain not just the immediate and direct link to opioids, but the opioid adjacent complications and side effects. You know, we actually have a little bit of hope. In 2022, CMS did approve a policy within hospital outpatient and ASC payment rules that are issuing payments for some of these non-opioid drugs and non-opioid biologics and biologic similars as supplies, but that only applies in the ambulatory surgery setting. And right now that doesn't happen on the inpatient side. That makes very little, if any, sense that it would work if it works so well in the outpatient setting that a lot of these same techniques, surgeries are similarly different, but similar enough that we could use those same techniques and have appropriate policy that recognizes those techniques, drugs and devices that would work on the inpatient side as well. So I think we're sort of seeing some incremental changes, but as an association, the AANA that represents the interests of CRNAs are working with our multiple coalition builders to try to ensure that regulators do understand that this is quite frankly an emergency. We have to be able to offer these opportunities for our patients across the entire spectrum, not just in a very sort of focused way only in the ASC setting, for example.
Thanks. We have another question of the audience that maybe you don't have to answer now, but maybe I'll read it and then maybe we can follow up offline. Are you aware of studies that you recommend health professionals review? And then if you can, to understand more about the use of non-opioid alternatives and overcoming the barriers, and for both of you, if you send them to me afterwards, we'll put it together and we'll get it out to our audience as a follow-up. So thank you to the audience for that question. Dr. Sinha, going back to you, what are the barriers, what do you see as the policy barriers to the widespread adoption of non-opioid?
The policy barriers essentially is these newer medications and devices. They are much more expensive, and they are not being reimbursed, as Drew alluded to, in the appropriate sort of setting. So we have a limitation on how we can use them to get better outcomes. And as Drew alluded to, it is downstream outcomes of better patient outcomes, better patient rehab, less complications, less opioid addiction, so societal benefits. All those things have to be sort of explained or be appreciated to help facilitate in early adoption of new medications and devices.
Thank you. And Drew, you mentioned earlier that there was a carrot and stick approach to the incentives to use opioids. And in particular, you mentioned the quality measurement. I wonder if you could start off really broadly about, what kind of quality measurement goes on and how does that influence clinician choices? And then maybe give some specific examples in the opioid space.
Sure. So broadly, we are tracking within the anesthesia space quality and quality outcomes, and this kind of runs the gamut across. Did the patient have appropriate pain control in the immediate postoperative period? Did the patient experience nausea or vomiting? If it was appropriate for the patient to have received an antibiotic, for example, in order to help prevent a surgical infection, was that the appropriate antibiotic and was the timing of the administration? So there's lots, and there's plenty more than that. In the opioid space in particular, there are some national quality standards around encouraging clinicians to think beyond just opioids for pain management. And that's not only acutely in the operating room and a decision that Dr. Sinha and I may make about what I'm going to administer to the patient, but then also our surgical colleagues on maybe managing that patient a bit more longer term when they get discharged from the hospital and go home. And the carrot and stick aspect of that, quite frankly, sometimes depends on the payer, but there are times in the CMS world where there are payment penalties if certain quality metrics or a certain benchmark is not met. And so while, of course, it's the right thing to do to really take great care of our patients, there may actually be a financial disincentive, if you will, a penalty within reimbursement to the individual provider if they're not meeting certain standards, certain benchmarks on those quality pieces. And Dr. Sinha, I don't know if you want to, in the ASC world, it's a little bit different, but there's, you may probably have something to add there for sure.
Yeah, I mean, you know, the things that we track are obviously you know, the amount of prescriptions, the amount of opioids that the patients have used. We try to reduce that. The states have opioid monitoring programs to try to sort of monitor and reduce it. You know, how many phone calls are made to surgeons' offices, or how many patients have so much pain that they come back into the emergency room for their management of pain that is not adequately controlled while they're at home. So these are some of the metrics that are sort of used, and that we should use. And when we try to implement new medications or new devices, these metrics serve as the foundation for trying to prove that the new medication or device is superior in terms of delivering the pain management.
Thank you. And Dr. Sinha, it looks like we're just about out of time. So what's the one thing you would like our audience to remember about our conversation today?
Well, I think I would encourage the audience to become more aware of the opioid crisis, but also when they are having procedures, to talk to their anesthesiologist or their clinicians about using opioid sparing medications, devices, and it's everybody has to sort of join in to be able to reduce this opioid burden and this opioid crisis.
Thank you. And Drew, I'll turn to you next for the final thought.
I agree exactly with what was just said. I think it's important to recognize from a policy perspective that I'd like our audience to realize and recognize that the clinicians and patients really want to have the best outcome possible, and that if policy interferes with that or gets in the way, it is not only potentially dangerous at worst case scenario, but it is really disheartening to not be able to offer a patient what may be the most appropriate technique, device, drug, whatever that may be for that episode of care, because there's policy that interferes with that clinical intervention. So we're trying the best we can with what we have. There's a lot of work to be done, but changing policy and regulatory barriers, removing those regulatory barriers to allow good pain control to happen is absolutely critical.
Thank you. This brings us to the end of this month's Northern Virginia Health Policy Forum. Thank you, Dr. Sinha and Drew, for joining us for your insights on non-opioid alternatives to pain management. I also want to thank the members of our audience for joining us today, and our applied policy team for their work on putting the forum together. I have one reminder before I close. Applied Policy has a monthly newsletter that discusses timely health policy topics. To receive our newsletter, you can find a link in the chat to join our mailing list. We'll also send this link in our follow-up communications to attendees, and we've included it on the Northern Virginia Health Policy Forum website, where you will find a summary of this presentation as well as video clips of the content. Thank you for being with us, and enjoy the rest of your day.